welcome back to another episode of the Gillett Health Podcast. And today's going to be a fun episode. We're taking advantage of our pharmacist being in town and thought it'd be great to sit down and talk about medications, side effects, drug interactions, the placebo effect, the nocebo effect, really from a pharmacist perspective, and get some expert information out there. So Ben, it's great to have you on the podcast. Great to have you in town as well. I'm looking forward to the conversation.
Yeah, thanks for having me. Really happy to be here. And let's get going. Yeah, I guess you mentioned placebo and nocebo. I think nocebo is one that I find really interesting. You just hear from people talking about their experience with the medications, and you don't want to say, no, that isn't real, because that is their experience, right? But sometimes you kind of want to take a look at the data, and you think, well, what is nocebo in the first place? The definition would be, there's actually two ways of having nocebo. The first one is you're part of a study, and you have a placebo group where they're given obviously a fake drug, that's a placebo, and they experience side effects, and sometimes even more than the group that takes the regular drug. So that is nocebo. That's something that should not happen, but it's happening. They have side effects, and it's not from the drug.
So this is a psychological phenomenon. The expectation effect is things we hear talked about. And it's how you can tell that a drug really works is because it's going to be better than giving somebody a sugar pill, but you're telling them they're going to get better.
Exactly. So a placebo is obviously the opposite, where they take a sugar pill, they don't know it's a sugar pill, they think it might be the drug, or they take the drug and they just feel so much better, and it doesn't really quite make sense because it should not work like that. So it's exaggerated in a positive effect, but the nocebo is exaggerated in negative effect. So when you're part of a study and you take a sugar pill and you start describing headache, erectile dysfunction, high blood pressure, it's not from the sugar pill, not a small amount of sugar in a capsule. So that's one way of having nocebo. It's when you're part of the fake medication group and you have all kinds of side effects. And the second way to get a nocebo effect is when you have negative expectations regarding your treatment. You go to a doctor and you get a script for a blood pressure medication. And then, so there are studies that show that when you get informed on the medication, you just get the name of the medication. That's already a 5x increase in side effects. And the one that was studied here was for atenolol, and there were three groups where the first group, they had a 3.1% incidence of erectile dysfunction. All right, so this is a beta blocker. It's for your heart health, and there's 3.3%, 3.1% that have erectile dysfunction.
So if I have a patient comes in, hey, we need to do something for your blood pressure. Here's a medication. I'm not telling them what it is. This is just for your blood pressure. Take
Right.
this. About 3 out of 100 people have erectile dysfunction.
Right. Although you would say no one does that, because it's not like this is your magic pill, and then you go to the pharmacy and the pharmacist is saying, yeah, this is for your heart, this is good, and that's it. It doesn't work like that. But in a non-biased environment where you just take a pill, 3%. Now if you give the medication to the patient and you just say this is the name, you give the patient sheet, you give the information on the drug, obviously like a regular medication, and then you go and you don't really get much more information. Now you have a 5x increase, like I said, 15.6 of the patients get some erectile dysfunction. So that's already quite a bit. It's just probably people that receive their medication, they kind of look at the sheet and then they see side effects, potential erectile dysfunction, 5x increase.
And that's the one that's going to jump out to people. So they're going to be writing down like, headache, dizzy, I don't care, erectile dysfunction. And then, so if I put 100 people on atenolol and I give them the information, 15 of those people are now going to have erectile dysfunction.
Yep. So that's quite significant. Now, the third group, and that's when you have a conscious, ethical health professional that wants to go through all the side effects and gives all the info to the patient, and they're doing their job, right? And so now the patient is made aware, because they would not have read the sheet otherwise, but now they're aware that there is a potential sexual side effect. And what is the percentage here? 31.2%. So that's a 10x increase from baseline. just because now they know that they may have sexual dysfunction. And guess what happens? 1 out of 3, they get sexual dysfunction.
So this drug may cause sexual dysfunction, but if I tell you about that, there's a 10 times higher risk that it's going to happen.
Exactly.
It's really interesting, and it does, you want the patient to take the medication, improve their health. You want the patient to also not have side effects from the medication. So, there's a big psychological component here, like we were talking about at the beginning. So are there some people who are like more susceptible to this? So, placebo non-responders? Is it people that are just very rational and they don't get side effects?
Well, there are optimistic patients that probably, will tell you, I don't care, I'll be okay. And they don't read the sheet and they don't really pay attention when you just tell them, there are side effects. Maybe they're like, I'm good. And they're probably going to be part of that first group, 3.1%. Now, that's for the optimistic patient, the optimistic ideal patient. Now you have a lot of more pessimistic patients. You also have external factors, such as someone else's personal experience with the drug. So they'll tell you, oh, this is really bad for you. So now they get concerned and they're trying to do some investigation. So now you can go online, obviously the internet, with a bunch of people telling you how bad some drug XYZ is for you. The media as well. Now you pay more attention to whatever big pharma company that is making the drug, or whatever horror stories that are out there. So, and I'm not saying they don't exist, but it becomes a little irrational where you actually go way too far, and now you're probably part of the second group, if not the third group, where you have a 5x increase or a 10x increase, as opposed to the first group where you do have side effects. There are 3% of people that get the side effects, and you can't really do too much about it besides changing the treatment. So you have to report to the doctor, and hopefully the doctor doesn't say it's on your head, because we know that some doctors would kind of invalidate the side effects. So that's probably not the best way to go. So there's also something to be said about health professionals, for sure. But there are strategies to kind of help people that get those side effects. But also a study was talking about some of the patients being predisposed to having more nocebo. So usually the usual suspects, having depression, having anxiety, having a more type A personality, neuroticism, and pessimism, where the big 5 here, with those type of patient profiles, being more predisposed to placebo.
Yeah, I can see that, because a lot of those conditions you already have, some physical symptoms at baseline. The people with depression have a lot of medical comorbidities a lot of times, and they could be having symptoms related to either the depression, to the medical conditions, or to the medication or placebo that they're getting. And I know with Parkinson's in particular, it's a dopaminergic disease, so they do respond better to placebo, probably also to nocebo as well, because I know the dopamine system and then also the endorphin system are heavily involved in that placebo response.
Yeah, that is true. And Parkinson's was one of the disease that I kind of highlighted. So there are a few, let me just pull it up real quick. Parkinson's, they were doing randomized controlled trials with a placebo group, and in a meta-analysis of 3,500 placebo-treated patients with Parkinson's disease, 64.7 reported at least one adverse effect, so side effects from a placebo in a Parkinson's group. And so why is that? Why is it that Parkinson's or depression or multiple sclerosis or epilepsy, those 5 where they had randomized controlled trial with placebo groups, and they all had more than 50%, if not 60%, if not 74% multiple sclerosis, of those people taking a sugar pill get side effects. And you can probably think that a lot of companies out there trying to have a new medication, or trying to recruit those people, or have a bunch of test subjects, and they may have a bad experience. So that's kind of back to the previous points, where what are the external factors that may be causing a lot of nocebo. And so a lot of the Parkinson's patients, multiple sclerosis, epilepsy, there's a bunch of studies all the time, and if you have a bad experience one time or twice, then that's it. You have a negative lab coat effect, so that's what nocebo is.
Yeah, I think that's a good point. You brought up, part of that is with the providers and their relationship with the patient. So if the patient, is very skeptical of their healthcare provider, they're going to go home, they're going to do their research, they go, oh, this medication causes all kinds of side effects. Why didn't my provider tell me about this? That's going to be a cycle of mistrust. And probably the way to position it is for a provider to say, hey, these are potential side effects that could happen with the medication. Realistically, X%, 90%, 95% of people take the medication, no problem. But if you do have side effects, let us know because there's always alternatives. And as a healthcare provider myself, I do try to pick medications that are better, cause less side effects, minimal effective doses. For the experts out there, I'm definitely not using atenolol as my first line treatment for elevated blood pressure, just for the sakes of the study. But then what about when nocebo effects don't go away? Because this is a really interesting data. You would think that with people who had either placebo or nocebo effect, tell them, yeah, you were in the placebo group, everything clicks and then they're all better. But what happens in those cases?
I can bring up one medication that is quite infamous out there online for its renowned side effect profile. It's finasteride for hair loss. There's finasteride, there's dutasteride, so both are 5-alpha reductase inhibitors, so they block the conversion of testosterone into DHT, dihydrotestosterone, which is a more potent androgen. So if you go logical about it, it's like, oh my God, I'm blocking testosterone from becoming more potent. So then I'm going to have side effects from not having enough testosterone or whatever. So a lot of people do a lot of research on this drug, especially because a lot of young men take this drug and they don't want to lose their hair. So that's what we see. And obviously they're more internet savvy or they like to do some research, Google, whatever. And you will find a bunch of websites that tell you, all the side effects and all the horror stories. And so what's interesting about this one is that there is a lot of persistent cases of issues and side effects from finasteride. Even though they stop taking the medication, they still have side effects. And again, you don't want to say it's all in your head. Like you don't want to have the typical 5-minute interaction with your doctor. It says it's all in your head. I have 1,000 patients and no one else has persistent symptoms. So it's been studied. Again, it's about 2% of the patients on finasteride that get post-finasteride. But then it's also been studied. Oh, my bad. It's been studied, and it was 4% with persistent symptoms. And it was studied versus placebo. So people who never took finasteride, and they described side effects, sexual side effects, from what would seem like low testosterone, sexual dysfunction, or low libido, or no ejaculation. So you name it. And there's a 3x increase between both groups when they just get the drug or when they get told everything about the potential bad side effects. So it goes from like a few percent to like 30-40%. So it's pretty much a coin flip. If you know about the side effects from finasteride, there's a pretty good chance you're going to get side effects from finasteride. So it's crazy because if you don't know and you just pop a pill, then you may have way less side effects. So yeah, what's persistent here is when you stop taking finasteride, 4% describe post-finasteride syndrome. There's no drugs anymore in their system. And in the placebo group, it's 2%. So which is crazy because they never took finasteride and they still have persistent side effects. So you're wondering, how do you have, side effects for the rest of your life? I mean, theoretically, or for months, if not years on end. And we do have the data where when you have post-finasteride syndrome, so even though you don't take the drug, the side effects kind of linger for months on end. Then you see about 50% recovery, and I believe that study was probably the follow-up was a few years. I'll need to double check that. Mm-hmm. But regardless, 50% recovery from that group that had persistent finasteride issues. And if you look at the placebo group, only 41% recovered. So you tell them this was not finasteride, you never took finasteride, you took a sugar pill, they don't believe you because now they have side effects and they don't go away. And they go online and they see post-finasteride syndrome and they think that's what they have. And like you don't really know how to explain that because you can probably pull up the data. You were part of the group that was placebo group, and so how do you explain this? I don't know. A good way to go is potentially testing, and that's what we recommend at Gillett Health when we have patients with post-finasteride syndrome. They can be part of the 4% that get post-finasteride syndrome. That's absolutely not a big deal. If you think about it, there's a lot of people that take finasteride. 4% of a big number.
Of every prescription written is a fairly large population.
Pretty large, right? And well, when we look at the data on finasteride, out of 100,000, recently there was a study, let me pull it up, there was 100,000 where about less than 0.1% discontinued treatment due to sexual dysfunction. So not a lot of people discontinue finasteride, but there's so many taking finasteride that eventually that 4% becomes maybe a few hundred or a few thousand in the United States. And out of 350 million people, well, it's mostly males taking the drug, but a lot of people take this drug, especially nowadays with hair loss. And we may see those people. So, when I'm talking to someone with post-finasteride, I'm like, well, let's see what's going on in your blood. We do blood work, and you want to make sure that there's no hormonal issue anywhere. And that's a big one. So there was a study from, what was it? The PROWESS, PROWESS, the PROSCAR Worldwide Efficacy and Safety Study that found that below 224 nanograms per deciliter, that's total testosterone. So total testosterone below 224, you have a higher risk of side effects from finasteride. So when we have those people, then we want to make sure that everything is in check otherwise, because testosterone is important, DHT is important, all that stuff.
And that cutoff makes a lot of sense to you and I sitting here talking because, of course, if you have low androgens at baseline, you have DHT that's also giving you some androgen signaling, but then you essentially eliminate or reduce DHT by 70%. And this is PROSCAR in this case, so that's a 5 milligram dose. Then you're going to maybe get a 5% increase in testosterone. That's not going to offset your reduction in DHT by 70%. And I think it is important work that some of the advocacy groups have done as far as post-finasteride syndrome, because this year actually the FDA did put a warning for it was either suicidal attempts or suicidal ideation on finasteride, because some people will take the medication and have some depression. We know that can be related to lack of androgens. So in part, is it a real phenomenon? Yes. And then is there also a psychological component to it? Also, yes. Just like you mentioned with the message boards. I mean, your ratio of people who have side effects and go to a message board, or go to a message board and have side effects, it's going to be much higher than somebody who just pops into Reddit and is like, oh, hey guys, I stopped losing my hair, everything's going well. That person has no reason to go into that community because their problem is solved.
Yeah, you see that all the time online for sure. I would say that it's important for us when we have someone who's concerned over the potential side effect profile to get them to do the right test. Give them reassurance. So when I have someone that comes to me and so I'm doing the intake calls, and someone asks me about hair loss, I say, well, you can probably do what we call a pre-finasteride kind of test, where you just look at all the hormones, and from there, although it's no guarantee, there's no obviously scientific method that just makes someone side effect proof to finasteride. But if you see testosterone, nice and high, and there's no imbalance anywhere, there's no vitamin deficiency, there's none of that. Prolactin is good. Prolactin correlates inversely with dopamine. So when you have high prolactin, you have potentially low dopamine, and vice versa. If you have prolactin in check, your dopamine levels are probably good. And DHT may be important for dopamine, right? So you piece everything together, and it's like, all right, you probably will do great on a low dose of finasteride. We can use 1 milligram, which is a low dose every day. PROSCAR is 5 milligrams, pretty aggressive dose for prostate cancer. But we do have people that may be a little scared, and they start slower. They start with 1 milligram twice a week, or 0.5 milligrams every other day. Like pretty much I've seen it all at this point. And it comes down to the patient trusting the doctor. So this is pretty big. You need to have psychology, spend some time with the patient, explain why there are side effects and what kind of context you can see. So if someone has low testosterone and then you give them finasteride, then they have low testosterone, low DHT, they don't have any signaling to the androgen receptor. So you may expect side effects from that. Actually, low estrogen is also important. You know that low libido usually is low estrogen in pretty much all animals, including humans. So yeah, low estrogen, not the best for libido. And if you have low testosterone in men, then there's a pretty decent risk that you have low estrogen. And when you go online and you talk to the people that may have persistent syndrome or persistent adverse events from finasteride, even though that was months, years ago, I rarely find blood work. Like that's not a thing. So maybe it's a matter of having access to blood work. Maybe it's a matter of cost because DHT is expensive. I know that I live in Canada. If I want to get DHT tested, it goes to the United States and then comes back. So it's just it's a whole thing, And I've seen other people online with DHT testing. It goes to the United States. So it's not easy. And then you go and you ask your primary care provider to test for DHT. I don't know how often that actually happens. And even just doctors that are more capable in the testosterone optimization field. Everybody tests for testosterone and estrogen, but not so much DHT. So, this is data that we don't really have. And when you have that data, you can actually give reassurance to your patient where they think they have post-finasteride, and then they will see testosterone is looking good, DHT is looking good, estrogen is looking good. Now we can go very advanced and look at neurotransmitters, urine testing for neurotransmitters. We see that, and if you investigate, and you may find something, and then you can just address it, and that is building a lot of trust in your provider. And if you find something and you address it, and then symptoms go away, now that's a success story.
Yeah, and I think if you're looking at it like the pre-finasteride screening, right, so making sure all your hormones are in check before you introduce another variable that's definitely going to skew different hormone levels. You go out the list, yep, prolactin's good, estradiol good, testosterone's good, yep, your DHT is in the not hair loss safe zone, so we need to lower that to some degree, and how much we need to lower it and what dose. And you go through and you put the patient on an individualized plan. You start the dose low, work your way up, and then they would tend to have a much better outcome than if I just took somebody out of the general population and said, hey dude, you're losing your hair, here's 5 milligrams of finasteride. That person is much more likely to have sexual dysfunction than the person who goes through this process, is working on getting their health in check and all these sorts of things before they introduce that variable. I think that's really beneficial. It just still is very bizarre to me with the persistent nocebo effect in that placebo group. So they never took finasteride and developed persistent sexual dysfunction over a relatively short time frame, because somebody's not going to develop something like coronary artery disease in that time frame where they've got no blood flow, or that's not like 2% of the patients aren't sprouting a pituitary prolactinoma or adenoma that's going to cause issues. So there's something there that's definitely psychological. And then I would be interested to see, I don't think these studies have been done, but looking at the different regions of brain connectivity. So we know those are disturbed in depression, for example, and there's work being done with transcutaneous magnetic stimulation, and that can get those pathways firing properly again. Then people are able to utilize the prefrontal cortex more. They kind of shift their view back to more optimistic. I would bet that there could be some research there in the future where you see these disrupted brain connection pathways and something like sexual dysfunction that is potentially psychogenic, and you say, oh, yeah, you've had this induction of neural dysfunction, and we can stimulate these areas and get things back online again.
That is something that research probably should be focusing on for sure. As of now, what could we do? I think that it comes back to education. It's just not here's the data. I mean, here's your medication sheet, and if you take a look at it, or if you go online, you will see all the bad stuff, right? It actually makes me think of something a little different, generics. I was kind of going through factors of poor response to treatment, and oftentimes you have generics in there because there's just a lack of trust in the doctor that prescribes generics. Or you just, you go and you grab, let's say you want a brand name, and then just, if you go and you get testosterone from a compounding pharmacy, I mean, that qualifies as generic, right? But it's not the brand name. So, and it's interesting because you can prove easily that the medication actually does what it's supposed to do. When it's something like testosterone, it's like, look, this is testosterone from the compounding pharmacy we work with, and it puts your levels around 1,000 where we want it to be. And if you got it from whatever brand name, then you would also be at 1,000. So that's pretty easy to prove with testosterone that generic actually works. Now, when it's something else, it's quite difficult because we have, there was a study about, I think in Germany, where they had 800 patients, and 2/3 did not trust the doctor, didn't spend enough time, didn't explain what was going on with the generic. Why substitution? Why would I not get the brand name? It's just a matter of saving money, so maybe there's a perception of, hey, this is cheaper, so it may be lower quality. There may not be as much quality control from the generic pharmaceutical manufacturer of the medication, instead of a big pharma where they have all those billions, and so they can do all the quality control. So it's very interesting, and that's one of the main things, quote unquote, that this is interesting. It may have been out there to save money for the German health insurance system.
And this was a patient that they interviewed, and that was their quote, talking about the difference between brand name and generic.
Yep, solving the financial crisis.
Yeah.
So it's not a real drug; it's just something to save money.
Yeah, and I think I can understand this perception, because if I go to the store and let's say I'm going to get, Cinnamon Toast Crunch, brand name, okay, and they're out, right, and all they have is, Cinnamon Toast Swirl Squares or whatever the generic name is. I think to myself, they're probably cutting some corners to make that product cheaper,
right?
But I want a Cinnamon Toast Crunch. So I can kind of follow the logic there. But the drugs that are generic, they go through a pretty rigorous process, at least here in the United States, as far as being approved. I would assume other countries have similar things.
Yep.
And I've heard this myth, I suppose you can tell me if it's a myth, that I've heard either providers or patients say, well, if it's generic, it could have a 45% variation. It could be, like you have 100 milligrams of a drug, there could be as little as 80 milligrams in that, or as much as 125 milligrams in that, which doesn't seem to be the case, but I'll let you explain a little bit about what that process looks like.
It's just a matter of confidence interval between, getting the exact amount, and so there's just 90% confidence interval here, just statistics, but in the real world, you're supposed to get 100 milligram, and that's going to be pretty damn close. So what you want to look at as well is where, when you have a generic, and if it's studied in a randomized controlled trial, if you see a difference between the generic and the brand name, and you just don't see that. There's just so many studies that are being done, and obviously there's a high level of quality control if you're a manufacturer of generics. You're pretty much, in the United States for sure, and Western Europe as well. You have to be compliant with the highest level of quality control, which is not the case if you want to get your cinnamon toast. It's just it's not the same way to it. Even with and what's confusing people is that even for over-the-counter supplements, for just your regular zinc and magnesium supplement, or just for your herbal, whatever supplement for testosterone boosters or anything like that, there's definitely a lack of stringent quality control. But in the pharmaceutical industry, it's an entire world. It's an entire beast. It's an entire different beast. Sorry.
Yeah, and you look at to get a generic approval, you have to have a randomized controlled trial pitting the generic against the brand name equivalent. And at the end of the study, everybody has to agree that these drugs work equally. And you're talking about, the confidence interval, that the drug exposure, the area under the curve, has to be, within that sort of, 80 to 125%. But if you're looking at the drugs and looking at the milligram amount in the drugs, you're not going to have that degree of variation.
No.
The reason you see differences is because you have different people metabolize drugs differently.
Absolutely.
So they want to get a large population and make sure that these things are actually going to be equivalent when they're applied at a population level.
Yeah. In no way, shape, or form would you have, let's say, Tylenol, and that's going to be 100 milligram for your kids, and then you have acetaminophen at 80 milligrams instead of 100 milligrams, or 125 instead of 100. That's just not happening. It's 100 milligrams. Now, yeah, there's obviously going to be differences in metabolism of in clearance of the medication. So then you have, absorption, you have distribution, metabolism, elimination, and all those factors are very different between one to another. And then you just you do see that difference in area under the curve. Again, it's pretty advanced statistics, and it's just there's so many different parameters right here at play where that may be confusing people. But the fact of the matter is, in that pill, you're pretty damn close to 100 milligrams no matter what.
Yeah. And maybe to wrap this up on a lighthearted note, something funny. Is upset stomach a drug allergy?
So that is interesting, because I know that we recently were talking about it. Let me quote it as well, because this is really interesting. Penicillin. A lot of people have heard of antibiotics, and penicillin had a historical reputation for causing allergy. Yeah, so penicillin is very interesting because a lot of people think they are allergic to penicillin, and quote unquote, because of their historical reputation, some medications may be more likely to have adverse effects. For example, penicillin allergy and a lot of upset stomach may be widely recognized by the public, and up to 10% of hospitalized patients say that they're allergic to penicillin. Whereas in a 2002 study on careful investigation, 97% of adults who were labeled as penicillin allergic were found to tolerate oral penicillin. So it sounds risky, because you have someone who says, I'm allergic to penicillin, and it may be because they had an upset stomach or just some sort of bloat or whatever. When under careful monitoring at the hospital with the investigators, 97% were actually fine.
Yeah, so they were able to give these people penicillin allergic, under careful supervision, so they could control if there's anaphylaxis, then
Absolutely.
They have a plan in place. But they give it to them and they're fine. And I think a lot of this, upset stomach, it gets flagged as an allergy. I see that in charts all the time. And then you also have, I had a rash. And I think a lot of healthcare providers make the jump, it's a rash. It's probably hives, and that, hives is along the same pathway as anaphylaxis. So, now we eliminate a whole class of drug and, cross-reactivity and all these sorts of things. When in reality, if you give someone, something like a penicillin or amoxicillin, and they have a viral infection, because we give too many antibiotics for viral infections when really we should be reserving those for bacterial infections. And then people will develop a rash because they have an active viral infection, typically maculopapular rash, which dermatologists will hate if you describe every rash as maculopapular and then send the patient to them. But as a side note, you see this rash that develops if a viral infection is present, but it's not a IgE-mediated hives rash that would precipitate something like anaphylaxis.
Right. And again, you don't want, I guess we can wrap it up the same way we started it. You don't want to invalidate someone and say, oh no, you're not allergic to penicillin. There's only a 3% chance. And again, it's the same figure. It's 3% of actually being sensitive to the drug. Mm-hmm. Like the same, there was atenolol 3.1%. Now here we're talking about 3% penicillin. So there's always going to be 3% or a few percent of the population. And again, in the United States, you have 350 million people. So that's like, what is 3% of that? That's probably 10 million. That's a lot of people, right? Yeah. So, you don't want to say to 10 million people, nah, that's all in your head. And you don't want to take the risk if they actually have a penicillin allergy. You're not going to give them penicillin and say, well, 97% of the time, it's going to work. You don't want to have this. It makes no sense, right? So you have to be careful for sure. But it's interesting how, potentially being influenced by someone else having a bloat or a stomach pain or, whatever, kind of gets you to be oversensitive to a medication. And that's pretty much nocebo. That's a negative expectation based on whatever factor, this time, external because of a bad rep for that specific drug. And stomach pain is not an allergy.
And evolutionarily, that makes sense because you have, a tribe of people, let's say, and somebody eats a plant and they get sick.
Right.
Well, don't eat that plant. Now we have the modern equivalent. Somebody takes a medication. It's like, oh, that medication made me feel really bad. So and now I know not to take that medication.
Yeah.
But one thing that I heard a long time ago, you maybe have a 1 in 10,000 chance of something happening, but that 1 in 10,000, somebody is that one of one, and they actually have that experience. So that's important to remember for us as a health clinic and providers.
Yep, better safe than sorry.
Yeah, but thanks so much for doing this interview. I think we covered a lot of good ground. I had a good time, and I think our listeners will get a lot of value from it. So thanks so much for coming on.
Thanks so much, James. Always a pleasure.